All right, Jess. I have you on like multiple times, but uh, remember since last time we hop on a podcast, probably like 3 years ago. That no, 4 years ago. That's before I came to the state, and before you took on another job and then resigned, and now like doing your own thing. So like, introduce yourself a little bit.
Yeah, my name's Jess Ellis. I'm a PT, so I've been practicing for I think it's 17 years now and have a decent eclectic experience between private practice, corporate PT, where I was pulling my hair out, wanting to quit. Then I got into Exos, worked there as a director of PT. I've done concierge work with tennis players, so kind of took on the whole one-on-one private sector, travel around the world, become, the massage therapist, nutritionist, and, strength coach and PT. And then got into the league and then worked with the Portland Trailblazers and the Knicks at the top position of a leadership overseeing medical and performance. Now I have a company called Rehab Code. So mentorship, education. I teach two different weekend courses, one on the shoulder neck, which we call the schneck with the rehab code, and then a knee course. And also, I also do consultation and work specifically for athletes that are dealing with issues. Basically, kind of doing what I was doing in the league, but now on the private sector side. So that's my 30-second pitch.
Nice, nice. So, obviously, like during the season, I text you about like some questions that I have. So, like I said, I deal with a lot of PT, AT, a lot of medical stuff before I went to the league or after. So, and you're actually one of the smartest. Um,
Thank you.
so yeah. So this is a tough one. I'm gonna start by asking you this. In the past few years, we've been talking about like ACL injury mechanism, Achilles tendon injury mechanism. We've been talking about tendon. Uh, and the league been doing like the league mandate every team to have this biomechanics lab. And I've been talking to like tendon expert like Jared Anflick, Ebony Rio, all those guys, and they're like, a lot of them were like, we're not getting anything out of the whole biomechanics testing. So, and our biomechanics testing compared to like other sports are, I don't really know, but so. Like, talk to me about share with me your thoughts on the whole biomechanics lab or like biomechanics testing.
So, first off, are you asking about my thoughts on the league-derived biomechanical assessment versus your internal biomechanical analysis? Because there's differences, right?
Yeah. So how about just start by like sharing your thoughts on like the league biomechanics test assessment.
I mean, I've talked to people in the league with kind of the direction that they're going for, and it's a tough task. That is very, very tough to do. So kudos to that group to say, we got to do something. We the injuries keep going up, and if we sit on our hands and just say, I don't know, let's just keep doing injury, analysis post the season to see what are the shitty correlations that we can find. Okay, so we are trying to become proactive. And the first thing is how committed are the teams to doing the NBA league standards? And that's going to be growing pains because everybody on that team think they're really smart and they have the equation to success. And then they have Big Brother saying, no, you need to do this as well. So there will be friction. Okay. And then secondly, there is friction between staff and player because players are going to say, hold on, you're going to do this league derived screen, and then you're going to want to do additional stuff with your internal analysis. And then the teams are stuck in a bad position because they're going to have to figure out what is the true appetite to the player. How much can you actually test before you can get mutiny on the ship. So I think that's where the teams have to say, what from the league do we like? And then how do we kind of enter, you know, put into some of this concepts are things that we believe are important. So I think, if anything, Eric, I think it's political.
Nice,
like
nice.
like most things in professional sports. So I think that's important, but really and truly, if we want to go back on the clinical side or more of the practitioner side, um, just because you can accrue a bunch of data does not mean that you can sift through it, create connections, create correlations. Now, AI is going to help us out. It will be able to crunch numbers better, and I think we'll be able to see better prevalences. It's just going to take a little bit of time. But right now, I think it's just we're taking all this data and we're collecting it and we're trying to figure out what are the most important pieces. And I think it's a blend between isolation. So you're profiling a force from an isolated manner on the things that you really care about, i.e., calf and quad. And then there's more, okay, let's look at the kinematics. Let's look at how the player moves and how possibly they compensate.
Nice. So, um, obviously, like different team have their own, like you said, different team had their own stuff to do, and with the in the league keep getting higher and higher, we keep getting more and more injury. Let's talk about this. Do you really think that everybody's been talking about like, oh, it's bad luck, it's bad luck? I mean, I get it, life happens, shit happens, but do you think it's all because of bad luck? Is there anything like as a practitioner, like in your experience, not pointing the finger at anyone, but like maybe we could do better at some stuff?
Yeah, I think we all can do better. I think we have to balance the fine line of using technology in a practical lens versus relying on it too heavily. And you see this now with AI, which is we have this beautiful tool that we can ask anything, and then human nature will always side towards laziness. And then this side is more practical. And what does it look like from an application piece? So I think that will be way more important as we start to figure this stuff out. I do think that it's really, you got to step back and say, what is this department made of? And I've worked in the setting and I've seen and I've talked to a lot of people in the league, and we have practitioners both on S&C and medical that can't even agree within their own department. So why the hell do you think that if you can't standardize your approach within your own team, how the hell do you think that's going to help with injuries? All
Hmm.
right. And I kind of explain this because I don't want a cult coming after me, but let's say it's a PRI centric team. I don't do PRI, but let's say this team all are in agreement. Strength, medical, it is a message, it is an echo chamber, all of that. It all will become the culture of that department. It is acculturation, which is the funneling of all of these opinions to then say, this is what we believe in. And I guarantee you that that department will be more successful than a department that is strained, that are highly intelligent, that can agree, because the players sense it. There's political friction and all the stuff that you should be doing as a group. It's just like the kinetic chain. It's just energy leaks. It's just bullshit. So let's talk about just getting the department laced up and in agreement. And I think that's the first part. Second part is, we got to look at the athletic development of these players and where they started from I talk about this with the wares of necessity. Like if you do the continual same thing over and over, pathology will set in, and that's a normal response. But if you start earlier, those wares of necessity become more prevalent, i.e., tendons and cartilage and menisci and all that. So we have to know that it's being developed, that the wares of necessity are being developed late or earlier in life. And I think that the game is getting longer, faster, stronger. The entry and exit velocity and momentum is at a different level, which means there's going to be more injuries in general because it's just moving at a higher clip, more possessions, and there's many more things you could talk about. But I think those are kind of the starting points.
Hmm. Um, well, I do agree with do agree with like a whole department constantly like probably not always agree with each other. There's a lot of friction all the time. And also agree with pathology. Let's talk about the speed of the game. Everybody's been talking about like the speed of the game increased so much in the past like 10 years, potentially because like we keep chasing output. We got force play, we got whatever it is. Um, but if we compare like the speed of basketball game to like the speed of football or hockey, like we still are a lot slower. But why are we like why are these injury keep showing up? And like let's say we have if we have a calf strain in a football team, they could like grade two calf strain, they could probably like get the athlete back in like 2 to 3 weeks. But if it comes to like basketball, it's like almost 6 weeks. If you rush it back, it's almost guaranteed like Achilles tendon tear. Why is that?
I mean, if I could answer that, I'd be a very, very rich man. So I will say there's a lot of factors involved, and clearly this is a loaded question. But I will tell you that I've worked with both type of athletes, and I mean, you have to look at the development of the athlete. Look at the NBA player. Very long, thinner. They're not as heavy. They use a lot of their ankle. They run on a stiffer ground, so ground contact time is shorter. And then think of it as it is a pretty much a half court game, which is mostly built up of acceleration, the first three steps, and then deceleration. So heavy quad on the decel with a little bit of flavor of soleus, and then excel constantly is that plantar flexors and tendon. So I think that is an issue, and I think the false step, like we can sit and talk about the false step because we do know that is the mechanism. I think that is the athlete trying to find more velocity within the game. It is a strategy to create the momentum while going back. They're already trying to, that's point A, there's my defender, and I have to beat them to either get around or get around a screen or get the ball. That's that tendency. And I think with the false step, I think sometimes when you have an Achilles issue or weakness, you can kind of find ways to play around it. But when that reflexive loose ball or a tipped pass, and now it's subconscious, and then you see that it pops. I think that's another aspect of, I think the athlete is able to kind of play around the pathology until it becomes reflex. And then that's where it goes.
Hmm.
So, and I've talked about this. There's been some, clinical dialogue on this. It's not my idea, but like the history of like a calf strain. Maybe they're not completely recovered there, but now there's a delayed firing to the gastroc head, which then if that takes a little bit longer to fire and there's already a descent to the heel, and then 2 milliseconds later, the calf fires, but it's already in the descent, then there's that forceful contraction, which then can lead to a tear.
So, I mean, if that's the case, like they're gonna do the fall step anyway. Does it really matter? Like we spend so much time talking about the calf, no, spend so many time talking about the fall step.
I think you can kind of try to um, find ways to teach around it for more conscious base, play style, but subconscious, you're not stopping it. It just happens. So that's where I think we can kind of, I don't know, I don't know what we can do as a team to stop that mechanism from happening. Now
Hmm.
you can start young and teach them don't do this, and let's try to be honest of ourselves and sport and all that and the above. There will be people that will say that that is important and that that's a talking point on social media, but I'm not gonna I'm not gonna fall on that sword.
Yeah. So, all right.
But to
Huh.
circle back, because I don't think it did a good enough job. I did a shitty job on the NFL side. I think these guys, one, if they're in a position that's more absolute speed, they can kind of clear out of that early acceleration. Style of play and positions are also interesting. I mean, I remember seeing, I think it was Kittles with a grade two calf strain, and he was like playing within a week. And I'm like, how the hell does that happen? And I, I just think there's a different mindset. There's less games, there's more weight to each game. And, you can inject them, you can support them with tape or, a neoprene sleeve or anything to get the gladiator back into the battlefield. I think that is the mindset of the NFL. And these dudes have much more muscle and they're just crazy strong. So I think they can kind of figure out a way to play through an injury a little bit more. And then
Nice.
hockey guys are just made out of titanium and just play through everything.
Yeah, that is kind of true. That is kind of true. I was actually talking to uh director of performance at a pro hockey league team. They're talking about like we train basketball players. They're like they're basically just pussies. I'm like, yeah, which is kind of true.
I When I was with the Knicks, I called my boss who was kind of overseeing the Rangers and the Knicks. And I said, "Hey, there's a player that he's got some nausea. He's got a little bit of a stomach ailment, and he says he can't go." And he was like on the phone. He goes, "Jess, do you know that I just got off the phone with the Rangers group, and there's a player that had a broken jaw with a metal plate put into it, and last night after 3 days of that surgery, the puck hit the same spot." So this plated jaw, this poor dude got hit within 3 or 4 days since surgery, and he's playing tonight. So you're telling me that this player has a stomach ache, while my other team is telling me that this guy's plated jaw was just damaged and destroyed from a puck, and he's still playing. I go, different, different sports.
Yeah, which is kind of true. Yeah, yeah, that's funny. So, uh, enough about like the caffeine. Uh, I want to ask you about this because I remember like saw you share your thoughts on like the ACL tear, and obviously like I said in the past few years we've been talking about the injury mechanism like deceleration, um, knees caving in, all that stuff. I think you kind of I think you kind of dive a little bit deeper. It's not just about like knees caving in. It's also about like when they decelerate. Uh, I forgot what is it. Can you like share with me?
Well, well, commonly a deceleration will be center mass is back, right? Trying to slow the momentum forward. You're going to stride out with your foot and you're going to land with more of a plantar flexed foot into the contact, which then gives all of this time for the soleus to decelerate the tibia, which helps because the soleus is the airbag. I don't know if I say the word right. Bag. I'm from North Dakota. I can't say it. The airbag, and that slows that initial momentum. And then the quad goes, "Oh, thanks, bro. You're helping me out." So that's one aspect is having that nice, basically we're talking about impulse and time and having enough time to stop. Now, there's other things that can happen. Let's say instead of having that nice plantar flex position of your foot, you land more midfoot. Well, that now changes the time demand for the soleus. So then soleus goes, okay, I got half the time to do my job. Sorry, I'm doing my best. And now the quad has to do more. So that's one aspect is placement or, navigating through chaos of sport. Then secondly, when you have not a great quad, so I kind of talk about a shitty roommate, right? If the soleus is having to do all the work and the quad is, paying rent half the time and the soleus has to pick up the other rent, well, that's going to lead to issues because soleus can decel so much, but there's going to be times where, hey, your patellar tendinopathy or your deconditioned quad, you better step up, and most of the time it can't. So then what happens is the knee will start to be more stiff. So you don't want to transition into that flexion moment, which means now there's just more vertical ground reaction forces to the innate structures of your cartilage and your menisci. So just and your bones. So it's just going to take more. And secondly, you can kind of fall into that trunk inclination angle. It can increase, which then says, hey, bro, up top here, your glute max, can you help me out? So that's the issue. I think it's landing with a stiff knee. It's sometimes foot placement that might not allow the soleus to, control momentum early on. Um, and then, the what is it, the Chinese finger trap? Or is that like, dude, you are so racist. That's not from China.
I don't know what you're talking about.
Okay. So it's this mechanism where you put your fingers in, okay? And when you pull out, you go, oh shit, I can't get my fingers out. So then you have to push them in and then it slackens the end and then you can get one finger out. But you, as a kid, get frantically, oh crap, I can't get my fingers up because of that traction. So when you land with a stiff knee, the femur and the tibia go like this. They compress, just like my fingers compressing in the finger trap. Now, what happens there? That ACL goes, oh, I'm a bit looser right now. So then the looseness says, I can shear better or I can shear more. And with speed, that shear leads to a tear. And then that impact of the compression, like I said, that condyle and the tibia compress. And then you look on the MRI and they have a really lit up lateral femoral condyle bone bruise. So that's kind of more of the mechanistic influence of an ACL tear is when you have a stiff knee, there's a surge in vertical ground reaction forces, which then creates that slackening because of the compression of the two joint surfaces.
Hmm. Nice, nice, perfect. So, you mentioned like there's uh soleus not strong enough, quads probably not strong enough, that kind of stuff. This kind of remind me like a few weeks ago I was talking to Ebony Rio and some other geriatric. They're talking about like Achilles tendinopathy and patellar tendinopathy, and they're like, um, if we have Achilles tendinopathy, we probably don't have our calf is probably not strong enough. If we have patellar tendinopathy, our quad's probably not strong enough. All right, so um, if we that's the case, but if we talk about like other stuff, like other injuries like hamstring, like groin,
So hold
yeah,
hold on for 1 sec. I want you to keep that thought.
yeah,
Okay, I don't want to have you forget your moment. That is too general of a statement. And I can say with tendinopathy, you will likely lead to some deconditioning or stress shielding because it hurts. But you have to say, what is the reason why you have the tendinopathy? And it could be that they compensate and use that limb more. So I don't want to be like, ow, pain, that's weak. We have to strengthen it. We have to say, hey, let's look at the other limb. Oh, shit, that's half the strength. Wait a second, that's mind blowing. Why are you not having pain on the left, but your right is very painful and you're twice as strong on that side? Oh, you're just compensating. You're doing too much on that side. So I think you got to step back and you really have to evaluate both. Case example, if you have a patient and they have pain with a squat, let's say it's your right knee, and you watch them squat and they basically shift onto that right side. Does that make sense to you?
Mm. Mhm.
That pain is on the right and they're shifting to the right. Now, what would
Yeah.
that tell you, Eric?
Too much load on the right side.
I would have to explore it. It would just ding in my mind say, I have to figure out what's going on here. And then you would do your isolated force profiling with a handheld dynamometer or IKD. You can look at some, you know, force plates and you go, wait a second, that's the source of your pain, but the cause is because you don't have a strong left quad. Or you got a really flat ass and you got no glute max, and that quad has to do more work. So I think we got to step back and say, hey, profession, I'm all for looking at isolation. But we got to kind of look at pulling the layers back to say, oh, yeah, he has generally a weak glute max. And guess what? He's got a history of low back pain on that side. And that probably cascade to an inefficient glute because it found ways to not work it. And then the quad had kick in.
Nice. I'm gonna dive a little bit deeper into this. So this might sound crazy or whatever, but like I was talking to like a few people about uh Achilles tendon tear, and some of them think like, yeah, like you mentioned, probably have weaker quad, and a lot of them say like either they lack hip internal rotation on the injured side or the other side, or they have SI joint issue. They have SI joint problem. Their SI joint is stuck. So thoughts on that?
Oh, you're going to make me eat my words. All right. I'm all about stepping back and looking at the whole movement sequence, the person, the history. I think we need to do that. But I'm now going to go back on what I just said. And this is the analogy I tell my mentees all the time. There is the forest ranger and there's arborist. And I think a lot of our practitioners are really good forest rangers. They're just trekking around the forest line. They see everything. They get back and they have the whole view. And I think we do a really shitty job of saying, especially with PTs, maybe not strength coaches, but the PT needs to be the arborist that looks at the tree. That is what I got to fix. I got to care. I got to make sure that it's safe in this environment. And then after I've figured out how healthy that tree is, then I'm going to step back, or maybe I'll go into the forest with the rangers. But I think for a PT, I think strength coaches are more of the ones that wander through the forest. I think the PT has to do, excuse my English, their fucking job, which is take care of the knee. Do they have quad strength? Do they even have full knee extension? Come on. Like how many post-surgical knees that we see that they have stiff knees and extension? Like it's because they could not get the quad to recruit at the early stages. And then the hamstring just held it in some flexion. But that's where I'm going to go back to say, yes, I was talking about finding the injury, and then looking at the hip, looking at the contralateral limb, I think you have to not just focus on, I'm going to check quad strength on this side. I think you look at everything else. You look at the quad and hip extension ratio. I think you look at the contralateral limb for an LSI. And I think then you can start to make a little bit more sense. But long-winded question, if we start playing around with SIJ dysfunctions and you have 3 more degrees of hip internal rotation on the right than the left, I think we've just got lost in the forest. Or
Hmm.
we're overstating some very generalized statements.
Hmm. All right. Followed by this. I want to ask you like when we deal with hamstring or when we deal with groin strain, like we kind of talk about a lot of time we use Nordic hamstring curl, Norboard or force frame to like test. Oh, their hamstring's probably weak. That's probably why uh they have hamstring strain in the first place. Oh, the groin is weak. That's probably why they have groin strain in the first place. So we keep doing that same thing, but like it just keep coming back up, right? Keep coming back. Thoughts on like uh all that.
You're not getting the athlete ready. If it's a recurrent injury, it's not able to take on the demands of the sport. So you can go Nordboard, you can do all the squeezes you want, but like, yeah, you can get some isometric testing for rate of force, but a lot of these injuries that happen, both of them, are speed specific. Look at the pennation angle of the hamstrings. It's much different than the calf. Calf can generate more absolute speed. Hamstrings, they sacrifice force for speed. It is a coordinative muscle. It is tied very closely to the nervous system and the sciatic nerve. And these long, you know, muscle attachments. And it's biarticular. It crosses hip and knee. This is a complicated fucking muscle. We have to play angles of hip and knee and understand the influence of that. Also, know we got 3 important hamstrings. Bicep fem, we got the short and long head, right? Pound for pound, it has the most cross sectional area and it generates the most absolute force. So when you do hamstring strengthening and you're going into those higher intensities, what you're going to find is there's going to be a tendency at some point with fatigue, they're going to roll their feet out. And then that shows you the dominance of that muscle group. Now, if you're dealing with a strain to that group and you do see the opposite, it's rolled in, now you're saying, well, that's abnormal because they're stress shielding the lateral side and they're pulling that medial hamstring in more. So then you would cue accordingly. But the bicep fem, I call it, I have some names for them, but the bicep fem is the whip. It has the most muscles. It's thick, just like a whip when you crack it. And most of the time, it is injured at terminal swing or in the process of terminal swing. Now you have the other two, which are your semi-mem and semi-tendinosis. Semi-tendinosis is not the whip. It is the bungee cord. And the bungee cord it doesn't have as much of that stiffness as the bicep does, but it has the mechanism of stretching, just like a bungee cord at end range. So semi-10 needs and can help that last overstretched position. That's when that can commonly get torn or injured. And most of the time, you injure it in the myoapneurotic zone of that muscle, which is that transition of muscle to tendon, which is proximal. You're going to see that more commonly there. And the third one is the leather belt, the semimembranosus. It's thick. It does not like to stretch. It has all of this apneurotic fibers throughout that complex. And just like a leather belt, you get that snap and it's done. And the semi-mem will kick in more and generate more of that time under tension and pull through the ground at mid stance. So you're going to have to know those angles to know where I'm going to train. So Nordmores are great, but they're great for certain ranges. If I really want to train those other the first two, I have to get the hip in a lot of flexion. I have to get the knee in some, shallow ranges of knee flexion, and I have to generate speed-based work. And there I'm going to know it. There's research to show that the short head of the bicep fem becomes hypertrophic when there's a long head injury. And there's your stress shield 101. Your body's finding a way to help remodel and strengthen the complex, but not in the area that is injured.
So, followed by this, apparently, like I have a track background, so deal with a lot of hamstring. What I what I seen is like if we instead of focusing on hamstring strength, if we look at like this is probably gonna sound stupid, but if we look at like if the pelvis is lying or not, or if someone has scoliosis, like that's probably gonna affect the length tension relationship from left to right, right? And somehow, like just my experience, like dealing with just focusing on the pelvis or focusing on the scoliosis, that actually help more than just hamstring strength. Thoughts on that?
I think that we can conceptualize to see that when you have poor lumbopelvic control, you will have a tendency to fall into an anterior pelvic tilt, which then will just create that resting tension in the hamstrings. They're just always in a little bit more elongated position. All right. We can all agree on that. And we can do our damn to try to fix it. Okay. I'm all for it. But I think we have to step back and say, let's do our due diligence and try to help it. And yes, the nervous system will figure itself out, but most of the time, I think the athlete will continue to do the pattern it has done for thousands of times. And what our job is to do is get this thing that's sensitized in pain and lower it to a point that now they can keep doing that pattern. But with all injuries, if you have an injury anywhere and you have postural flaws that will make that a challenge, those postural flaws were beforehand and we're not going to fix it. We have to calm the system to then get back to what they were able to do before. But when you have shitty posture and you have now an irritated tissue, you feel it every time.
Hmm.
Just like when I talk about the beast of the cartilage, you might have had it a long time. It doesn't just happen unless it's actually a shearing injury where it's macro trauma, but most of the time it just takes chronic loading. And then
Hmm.
at one point, it flares up. And then all of your shitty mechanics, like genu valgus that you did every time your whole entire life, that actually hurts now. I'm not going to fix that. I got to calm it down so they are tolerable to keep doing that shitty pattern that they've done forever. I think we got
Hmm.
to look at it more like that. And that would be a practical way to look at an injury.
Hmm. Love it. Love it. All right. We'll talk about hamstring. What about groin?
Groin is complicated. It is this nice, efficient system that go back and forth on the other limb. And they are very coordinative and they, you know, you see it a lot with knee injuries too, or a deconditioned knee. The adductor helps a lot. One, it drives into that valgus. It helps with hip extension, the adductor magnus. So I think that's a way to compensate through a different system to generate the demands to be successful in your task. Adductor longus, is the most common injury of the group, and reason is the attachment of that muscle is the most anterior to the pubic symphysis, which means it has the longest mechanical arm. And not just the longest moment arm, it also is a pretty thin muscle. It's not as robust as your adductor magnus or your pectineus, right? It's a little bit more, you know, circular, but more like it's just longer, hence the longest name. But what I find is, we can train that adductor complex, specifically longus, in a neutral position of the hip. That's fine. But like for you to do a Copenhagen to that muscle group, you need to rise up into that normal neutral position and then dropping your center of mass forward and pushing forward. Now you're getting the combination of adduction and extension, which is now putting that muscle in a more outer range position, which then you need to train because that's usually the position that you will injure. So you work time under tension, you get tolerance to those positions, and then you go into more ballistic style isometrics. And a lot of those, I'll get them in positions like a really elongated split stance, but with that back hip not only in extension, but in abduction. Let's say the front leg is up on a box and the left leg is in abduction and extension. And let's say he's doing a pallet press or some kind of core exercise. I'm actually by the foot and quickly pulling the adductors and more stretch, and he or she has to react. So I'm getting the positions where they're going to strain, and then it's rate specific ISOs.
Hmm. I love this. I love this. So,
But
uh,
in general, with I just think we don't get enough strength to both the global but also the injured tissue. And I do think that if we don't clean it up, you're going to get closer to a problem like sportsman hernia, which now you're dealing with the attachment point to the pubic ramus or just the pubic symphysis with the lower abdominal musculature and
hmm.
that rectus abdominis. So I think if you don't clear it up, there's likely going to be either a contralateral adductor strain or more of this inflammatory lower abdominal injury.
Hmm. Nice, nice. All right. So we talk about a lot of injuries. Um, Want to go backtrack a little bit, like I asked you earlier before about the whole biomechanics stuff, and people also look into like the pathology, all that stuff, imaging. And we talk about like is the tissue or the muscle strong enough to handle those load? Hmm. Some would say like uh if you don't think fix the biomechanics, it's gonna be okay until it's not. And after, like you said, after you feel something, it's just gonna always be there. So well, I guess my question is like, how do you balance all these approach with all these like different like you got biomechanics whatsoever, you got pathology or the tissues probably like degenerative, all that stuff, and at the same time like are the muscles strong enough?
I think that we have to step back, and I think it's the next phase in how we understand injury prevalence and how do we mitigate it. That is using this technology to then create an athletic profile to a certain person. And if we could start to bucket these athletes in specific categories or labels that at least I don't want to bastardize it and make it too simplified, but we also just can't cast this crazy net and then try to find what these variables mean to all of these athletes. But like their style of play, their history, their age, and you would start to bucket them in these profiles or, athletic prototypes. And then from there, you go, okay, now I'm looking at this subgroup of an athlete and where are their tendencies to have injury. So an example would be there are NBA players that are high flyers. They're very tendinous. You put them on the table and they're really stiff. Like, is that a bad thing? Do we try to get more mobility and flexibility, or are they just a human spring that is extremely efficient? So I look at the efficiency there to say, well, what would that injury lead to in this case early on? But let's see, year 7 with those springs, they are different now. And do they have to change their style of play to survive their career? Because their athletic capacities were dictated based on things that might have changed with age. So I think that would be a high flyer or a tendinous based athlete. And then you look at somebody that doesn't have a great vertical, that are pretty good at lateral movement, because most high flyers don't move great laterally. They get up, they go sagittal. So people that are lower, more compact, more muscular, change of direction might be a little cleaner. Like those injuries might be different. Maybe I look at the muscular system versus a tendinopathy. And then I look at their history of what injuries happen. So now I know that they have a higher chance of this type of injury because they've had it in the past. And then we have to do our job to screen it out to see where are they at? Are they still suboptimal, or is this system actually back to where they were pre-injury? I think that's important. That's like low hanging fruit shit where you find the things that were previous injured and are they truly back to 100% capacity where they need to be? Or are there still deficits? Let's start there. Let's just start there. And
Mm,
then we can start to roll out and travel in the forest and look at everything else. Let's tend to the tree. Let's fix that first.
I love
But
this one.
anyway, long-winded question, like all my answers. Sorry, long-winded answer. Um, I would just say that we are going to start to collect this information, and then we should be able to start to subgroup athletes.
Nice, nice. I love it. Love it. All right, last part. Um, Obviously, like pro sport, there's like strength coaches, PT, athletic trainer. Um, and how do you manage those times when like people don't agree with each other?
Well, I think we all have to own up that we have an ego, and we all have to know that there are some people that are more aware of their egos and some that don't. And then I think another piece is you got to step back and just dealing with humans our entire lives, you start to say, how much can I change someone? Or how much is it just them? So, from like a department lead kind of overseeing teams, the leader's job is to say, how moldable is this person versus this person is who they are, both strengths and flaws. We all are imperfect humans. We have to agree on that. And then the last question that I would then follow up with as a leader is that flaw worth the fight? Is it worth the argument, the conflict, the exposure, the passive aggressiveness after the conversation? Or it's just, you know what? That's Eric, and I'm going to accept Eric who he is. And guess what? As I get to know Eric better, maybe I can pull him aside and say, hey, man, I just want you to know that when I first met you, you had these tendencies here. And since then, your stubbornness has gotten, you've become more adaptable in that setting. So what you're doing is you are giving um, some critique to someone, but showing it in a way that they're improving. And then Eric, you will be like, all right, dude, I appreciate that. Because you're taking it like a compliment, but you're also saying like, oh, okay, that was a problem. I still need to get better. So is the flaw worth the fight? How much can we change? That's why it is so important to hire the right people. And if it takes 5 to 6 to 7 interviews to get it right.
Nice. Nice.
Because one person in a department can destroy the whole thing.
Hmm. Yeah. Nice. I love it. I love it. All right. That's all I have for today, man. Thanks.
Awesome. Appreciate you, man.